afternoon, and welcome to our next session for the Vancouver Patient Forum. I'd like to introduce you to the Min Batan, who will introduce the session. Min?
Hi, good morning to everyone, and thank you for coming in. Fran and I would like to thank everybody, our speakers especially, Dr. Chris Ryerson, Dr. Wilcox, and Dr. Alyson Wong. I'll turn it over to Fran.
Welcome to everybody that's joining, and especially to those who have never been with our support group before. We've got a wonderful group here on the West Coast, and anybody that wants to climb in and be part of it with either this webinar and hopefully a future gathering in a virtual session. I've got a great lineup for you, and we'll be able to talk to you after it's over. We've got one session there that is going to be devoted to the support group people, and that's any of you around the world that want to join. Thanks, and I'll hand it over to Chris. Dr. Ryerson.
No. Okay, let me just introduce Sharon.
Okay.
Who is the CEO of the Canadian Pulmonary Fibrosis Foundation, and she is one of the backbone for putting together this forum.
Okay. Thank you, Min. And I want to say thank you, everyone, for joining us. As you know, CPFF is very proud to present this year. Due to COVID, we recognize it's still a need for a patient forum, and we are so pleased that the Vancouver Patient Forum is part of this. And as Min and Fran have indicated, this is happening the whole month of September. We have great speakers across the country, people like Dr. Pierce and Dr. Alyson Wong and Chris Ryerson. It's a great session. And if you haven't registered, just go to hopebreezhere.com and you can follow us on social media. Thank you so much. And I turn this back to Min.
And of course, we will hear from our very young President and CEO of the BC Lung Association, who is really very supportive in this kind of endeavor. So turn it over to you, Chris.
Thank you, Dr. Biagtan. And what I really want to say is I'm so incredibly impressed with our ability to convene like this. And I want to welcome everybody to a uniquely special way for us to gather, to share, and for us to learn. Big thank you, of course, to Sharon and your great organization for putting this all together. And of course, Fran and Men and the rest of the team for really making this all happen. It's an incredible endeavor, particularly in this time. At the BC Lung Association, we're collaborating with such incredible people. And those people are actually on this call as well. And I'm excited that they were able to join us. This incredible initiative that we're starting is something called the Lung Transplant House of British Columbia. Its entire point is that it would provide housing assistance to BC lung transplant patients and caregivers. It's an urgent problem with very few solutions. And that, I have to tell you, is being incredibly driven by volunteers and patients like yourselves. On this call right now, I'm pretty sure Bob Meller's on here. I know Darcy Murdoch, who many of you know, would like to have been on this call as well. And of course, Dennis Josie. The three of them are really driving this. And I'm inviting everybody on this call to join us and join them in this incredibly collaborative mission. If you want to find out more, it's at lthousebc.ca. It's an incredible initiative for people who really need support as they're going through their lung transplants here in British Columbia. What's notable about this is that, of course, Bob and Darcy are IPF survivors. And I know that that's going to resonate with a lot of people in this room. This truly is a patient and caregiver-driven initiative that we are incredibly proud to support. And we are incredibly proud to support all the people who are on this meeting right now. So without further ado, I'm going to turn it over to Dr. Chris Ryerson, who's going to moderate this. I wish you all the very best in learning and sharing and collaborating today. So take it from there, Dr. Ryerson.
Thanks, everyone, for the support in putting this all together. This is obviously a trying time for all of us, but also a time with a lot of great opportunities for us to take a step to the future. I remember starting our support group with me and Fran, and with Fran and I there, I think we were an equal number to the number of patients that ended up coming to our first support group meeting. We literally had 2 patients that came to our first one about 8 years ago or so. And since then, we've grown to a large community that's been very active on the West Coast. And it's been great to see what we've been able to accomplish, as Chris and Men and Sharon have said. And this, I think, is another step forward. We've had a patient forum for 5 or 6 years now on an annual basis. And it's grown in recent years to 100, 150 people, patients and caregivers that would come to this. And it's great to see everybody in person. Unfortunately, obviously, we can't do that this year. But as a consequence, we're actually able, I hope, to reach even more people than we have in the past. And so I think this is something that we'll have to think about continuing in this kind of format, even if we are able to meet face-to-face next year. And hopefully we will be able to do that. So without further ado, I'm going to just give a brief outline and then get started. So I'm going to give my first talk for about half an hour. Dr. Wong, I'll introduce in a minute, but she will give our next talk for half an hour. And then we've got lots of time for questions that will be moderated by Dr. Wilcox. And then I think afterwards, as Fran mentioned, there will be some time for people to discuss things a little bit more about the support group and future endeavors. So without further ado, I'm going to get started on my component of this. So the first part of this talk is really to give an outline of the past, present, and future of pulmonary fibrosis. This is a common talk that I've given before, with parts of this given before. So some of this will be familiar to you, but repetition is always helpful, I think. I have a few disclosures. I'll talk about a couple of the medications listed at the top here, nintedanib and pirfenidone in particular, as well as mycophenolate. The main objectives really are to give a quick overview of interstitial lung disease, and we'll talk specifically about some of the new advances in both the diagnosis and management of fibrotic interstitial lung disease. And I'll try to explain all these abbreviations as we go. I'll talk about ILD in terms of interstitial lung disease, and then we'll talk about IPF, which is idiopathic pulmonary fibrosis, and I'll explain what both of those terms mean. We will talk about antifibrotic medications. We'll talk about new diagnostic guidelines and therapeutic approaches and diagnostic approaches. And then we'll talk about cryobiopsy, which is an interesting new technique that isn't available in lots of North America places yet, but is probably coming soon. So this is a picture of a normal lung on biopsy. This is a very microscopic picture. So this is the very lace-like architecture of the alveoli in the lung, which are really where gas exchange happens. And this is entirely normal. You have very, very thin lace-like alveoli scattered throughout here. This is what fibrosis looks like. So you can see that there's a lot of dense pink stuff, which is fibrous or scar tissue. There are a lot of little purple circles in some of these, especially in the lower right figure. Those are little inflammatory cells that you can kind of make out here that are really, really tiny. So this is what we see with fibrosis, often which goes along with inflammation. And you can imagine that gas exchange or oxygen exchange doesn't happen very well when you've got a whole bunch of this dense fibrous tissue that the oxygen needs to diffuse across. There is an alphabet soup of interstitial lung disease. This is just some of the abbreviations that we think about and talk about all the time. I'm going to try to not mention too many abbreviations as we go through, but I'm going to focus on a few of these. That's ILD, PF, and IPF. And what these are, to start with, interstitial lung disease is synonymous with diffuse parenchymal lung disease. We usually just talk about ILD because DPLD is a little bit more of a mouthful. So ILD is an umbrella term, literally includes a couple hundred different subtypes of interstitial lung disease. So a couple hundred different subtypes of diseases that cause scarring or inflammation of the lung. Pulmonary fibrosis is a subtype of that. So if you have an interstitial lung disease with some scarring, we call that pulmonary fibrosis. Within pulmonary fibrosis, there are also a whole bunch of other diagnoses. People will have probably heard about IPF, or idiopathic pulmonary fibrosis. And that's what is represented here. So ILD is a big group of diagnoses. PF is a big subgroup of that. And then IPF is a very specific diagnosis that's a subgroup of pulmonary fibrosis. There are a whole bunch of other things. This is connective tissue disease associated interstitial lung disease, which is a group of autoimmune diseases. This is hypersensitivity pneumonitis, which is another group of inflammatory and fibrotic disorders of the lung. And there are a whole bunch of other circles that I could draw on here of a whole bunch of other diagnoses. But these are three of the more common ones that we think about on a daily basis in our clinic. If we look at the breakdown of what we see, this is from our registry, Canadian Registry for Pulmonary Fibrosis. We can see that autoimmune diseases actually make up the largest percentage of patients that we see at 37%. IPF is about a quarter of what we see. About 20% we can't confidently classify as a specific diagnosis. HP or hypersensitivity pneumonitis is about 7%. And then there's a whole smattering of others that make up the last 12% or so. So really what we talk about a lot is connective tissue disease, IPF, unclassifiable, HP, and then kind of everything else. When we think about the diagnostic process, there are a few things that we think about in every patient. We obviously ask patients about different exposures that they may have had, different autoimmune features, history of smoking, things like that. There are some blood tests that we do to look for autoimmune causes of their pulmonary fibrosis or of their interstitial lung disease. We also look at pulmonary function tests, and then CT scan is really the main diagnostic test. And often we can make a diagnosis based on these first four things: the history, the blood tests, the pulmonary function tests, and the CT scan, which is a fancy imaging technique. Sometimes we don't have a specific diagnosis, and then we have to go on and do things like a bronchoscopy or a lung biopsy and others. And I'll talk a little bit more about those in a minute. To give a few examples, these are three different made-up cases. The first one, a 55-year-old who's had 3 months of dyspnea, which means shortness of breath, and a dry cough, and they've got some mold exposure. And the CT scan shows a whole bunch of inflammatory change. You'll have to take my word for it if you haven't seen a lot of these. And then the biopsy shows features that are really suggestive of hypersensitivity pneumonitis. Next case, this is a 67-year-old man who's had 1 year of shortness of breath and dry cough, doesn't have any clear etiology identified, and his CT scan looks very fibrotic. This is what we would call honeycombing, and a usual interstitial pneumonia pattern, which I'll explain in a little bit. And the biopsy again shows a whole lot of fibrosis, and this is what we would call idiopathic pulmonary fibrosis. Third case, this is a 43-year-old woman who's had 6 months of shortness of breath and a dry cough and has systemic sclerosis or scleroderma. And a CT scan, this shows an NSIP pattern. The biopsy shows the same, and so this would be a connective tissue disease. So this just gives you an idea of a few different things and what those cases might look like on a typical patient. Sometimes it's not that classic, and when things aren't that classic, we talk about the diagnosis as a group, and that includes a clinician, a radiologist, and a pathologist usually. We call this a multidisciplinary discussion with each of these three disciplines, and we put our heads together, discuss the case, and come to a consensus diagnosis. This is challenging. You can't just do this with any respirologist, any radiologist, any pathologist. You want to have experienced people who are participating in this. So you want an ILD expert, you want a chest radiologist who really knows about lung imaging, and you want a lung pathologist who's looked at a lot of biopsies. If you go and try to do this in the community with physicians who are not as expert in this area or not as experienced in this area, they less frequently agree on the diagnosis, and they're more likely to make the wrong diagnosis. And they're also more likely to call things IPF than what we would call things when we were looking at it as our multidisciplinary conference. So a lot of patients, when they come to us with a diagnosis of IPF, we actually end up changing it to a different diagnosis after looking at things more carefully. Where that expertise lies in BC, so for those of you from Canada who are on the call, this is British Columbia. Vancouver is right down here, and this is where the only ILD centers are in the province. So you can imagine there's a whole lot of geography up here and a lot of patients where they don't have access, or at least they don't have easy access to our clinics, which are focused in Vancouver. One of the things that we did a couple years ago, several years ago now, is we started reviewing cases from out in the community where there was diagnostic uncertainty and the patient wasn't able to travel to us. And we would review their clinical files, their imaging, without actually having the patient come to see us in person. This is a publication that we used or that we published about a year ago based on this experience. And essentially what we do is if we see somebody in clinic, if I see a patient in clinic and they have a clear diagnosis, that's great, we're kind of done. We can make forward some treatment recommendations. If they have an unclear diagnosis, then we review them in our ILD conference with that multidisciplinary discussion. There's also some patients who are seen by other respirologists. They have an unclear diagnosis and can't come to Vancouver, and we'll review them in our ILD conference without seeing that patient in person. When we do that, we have about half of patients that we change the diagnosis on, almost half where we change the treatment. And we're able to do that about 80% faster than if this patient was referred to us and then seen in clinic and then reviewed. So it's a very nice service that patients and the referring physicians really valued. A lot of the time, as I mentioned, the approach to diagnosis is unclear, and that leads us to thinking about things like biopsies. There are two main ways that we do biopsies for patients with interstitial lung disease. One is what's called a surgical lung biopsy. Nowadays, we do this using what's called video-assisted thoracoscopic biopsy. So this is where you have little keyholes. These are all about 1 or 2 centimeters in length, and you have these little instruments that go in through these keyholes, and you take out little pieces of the lung that can then be looked at under a microscope. The problems with this is that it requires a general anesthetic and a thoracic surgeon, which sometimes are hard to come by. There's a risk of complications, especially in older patients, those with more severe disease, those with other medical issues, and so on. And so we're unable to perform this procedure in a substantial percentage of patients. And this is why a lot of that 20% of patients that I mentioned with unclassifiable interstitial lung disease, the inability to get a surgical lung biopsy is often why those patients remain unclassifiable. So that's brought us to thinking about other approaches to getting some little pieces of lung tissue to look at under a microscope. And this is what this is a picture of a cryobiopsy. So bronchoscopy, which many of you will have heard about, involves taking this camera and bringing it down through the vocal cords into the lungs. It's about the size or the diameter of a pencil, so it's not very big. And we go through and we can take some samples out. When we do this normally, we get very small samples, and that led to the creation of a new technique called cryobiopsy, which is what you can see in the bottom right here. And this is frost on here. Cryobiopsy means that you make the end of this really, really cold, and it freezes the lung tissue, and then you can pull out that frozen lung tissue, and you can get bigger pieces of tissue that are less prone to sampling error. They're also less prone to what we call crush artifact, which if you were taking a little bite of a tissue with what we call alligator forceps, which really it is what it sounds like, you can crush all of the delicate lung structures, and it makes it harder for the pathologist to look at that. So cryobiopsy is a new and very promising technique that's had a lot of controversy over the last few years. The idea of this, again, is that there would be lower risk of complications compared to a surgical lung biopsy. And you're able to then do this in more patients than the surgical lung biopsy can be done in. This is a meta-analysis, which is basically pulling together a whole bunch of different studies that we published a few years ago. There were 11 studies that we looked at, one that was from the US, and then the rest are all from Europe, with one in Israel as well. There were 731 patients in this. And basically what we did was we pulled all of the data from these different studies to show the yield and the risk of complications of this cryobiopsy technique that had been published to date. This shows the summary of the yield of the cryobiopsy. Overall, it was 83% yield. And you don't need to know how to interpret this too much, but basically this comes down to an 83% yield. So 83% of cryobiopsies end up having a pathologist who says, this is what I think is going on, and they're reasonably confident about stuff. The problem is that the pathologist gives you an answer, but there is still a risk of sampling bias because these are still relatively small biopsies. And so even if the pathologist can give you an answer, it might not be the right answer compared to what you would have gotten from a bigger surgical lung biopsy. So that's one of the big caveats to this. In terms of complication rates, pneumothorax or a collapsed lung was about 12%, moderate or severe bleeding was about 39%. The problem with these is that it's very heterogeneous. So some studies did really well and some studies had very high rates of complication. So it really seemed to be operator dependent. So it depended on who was doing the procedure and what exact technique they were using. So it's not as safe in some hands as you would like it to be. So after this study, there were two camps really. One from Europe mostly that said cryobiopsy is really awesome. It has a high yield. We're very confident in our answers. It's very safe. And then there was another camp, mostly from North America, saying, hold on a sec, there are some problems with these studies. Being confident doesn't mean that you're right. And there are potential complications if you're not doing this correctly. This led to a study that was published a year ago now, showing poor concordance, so a lot of disagreement between cryobiopsy and surgical lung biopsy. So again, cryobiopsy being these smaller pieces from that frozen bronchoscope, surgical lung biopsy being the bigger pieces that you get from an actual operation. And this study showed that cryobiopsy was not providing an accurate diagnosis compared to what a surgical biopsy tells you. And this led to people being very concerned about cryobiopsy being misleading, of course. There's another study published just earlier this year that has put a lot of this to rest. This was a really well done study out of Australia and one of the key publications of the last year in interstitial lung disease. So this is the cold ice study, which all good studies have nice acronyms like this nowadays. And they did a very nice study design. They reviewed patients in a conference like I discussed before, and then patients underwent both a cryobiopsy and a video-assisted thoracoscopic surgical biopsy, so the surgical biopsy that I talked about. So every patient underwent both of these procedures, and then they compared the results of these two procedures against one another. And they had two things that they really looked at. They looked at the agreement between what the pathologist said from each of these types of biopsies. And again, this is a cryobiopsy and this is that surgical biopsy. And then they also looked at how much agreement there was after you reviewed everything in that ILD conference or that multidisciplinary discussion. And I'll go through the results of this in a little bit of detail. So first of all, the surgical biopsies are about 7 times bigger than cryobiopsies. In terms of the area of these biopsies. The diagnostic agreement between the two is 77%, which is pretty good. If you had a cryobiopsy that the pathologist was confident in, then you actually had 95% agreement. So if the pathologist was confident, you're doing pretty well. If the pathologist wasn't confident, then they were not confident for a reason. They had a surgical biopsy that was also difficult to interpret. 6 out of 26 patients with a low confidence transbronchial lung cryobiopsy ended up having a high confidence diagnosis after their surgical biopsy. So it shows that if you had a low confidence cryobiopsy, the utility of going on to a surgical lung biopsy was actually pretty low. Only about 1/4 of people ended up having a diagnosis at that point. So where that disagreement happened is shown here. So this is looking at the biopsy pattern that a pathologist looked at. You can have a few different categories here. There's an alternative diagnosis suggested, there's an indeterminate for UIP, and then probable UIP and UIP. You don't have to know too much about what each of these terms mean, but the disagreement you can see here happened in this UIP kind of category. And essentially what happened is that if you have a cryobiopsy, the pathologist lacked confidence in calling it UIP. And the pathologist lacked confidence because this is a smaller sample, and they were therefore a little bit more hesitant to go all the way and say this is UIP. They instead just said it's probable UIP. On the other hand, if you have a big surgical biopsy, the pathologist is then confident. So essentially the big surgical biopsy is really moving patients from this probable to a definite UIP pattern. And that allows you to give a diagnosis of IPF in those patients. When you put things all together into that conversation, that discussion that you have with the clinician, the radiologist, and the pathologist, you actually don't have any disagreement anymore, or you have very little. So both of these groups with probable UIP or definite UIP on the biopsy end up being called IPF. So we're able to overcome some of the issues with cryobiopsy by talking things through in that multidisciplinary group with the respirologist, the pathologist, and the radiologist. So this study showed that there was good concordance with cryobiopsy and that we should be thinking about doing that procedure more often than we have been in the past. And that would allow patients to go forward without having that surgical lung biopsy. This is another study published earlier this year, looking at what treatments are we going to use depending on how likely IPF is. So this was a survey of 404 ILD experts. Each of those experts looked at 60 cases and provided their opinion on what they thought the best diagnostic approach should be and what the best management options were. And you can see here their confidence in IPF going from not at all confidence or not thinking that this is IPF to a low confidence diagnosis of IPF, a high confidence diagnosis of IPF, and what we would consider a definite diagnosis of IPF. So if you have a definite diagnosis of IPF, you're very likely to use IPF treatment. But even if you have a low confidence in the diagnosis of IPF, so 50 to 90%, the vast majority of patients are still going to be offered IPF therapy. So this suggests that most experts will use IPF therapy or suggest IPF therapy to a patient, even if they aren't fully confident in the diagnosis. So this again tells us that maybe we don't need that surgical lung biopsy to prove the diagnosis beyond any doubt. Maybe we should be using IPF therapy even without all of that confidence behind us. So conclusions from this first part, cryobiopsy may be a helpful diagnostic tool, but there is significant risk for misinterpretation if you're not careful about this. Most patients, it really is just changing your confidence in the diagnosis based on the biopsy pattern. And this multidisciplinary discussion or that ILD conference is able to overcome that minor difference, usually by assigning a diagnosis of IPF for those patients that had a low confidence diagnosis beforehand. I haven't talked about it today, but there are additional less invasive tests that may also be coming. There are other bronchoscopic tools, some genetics, and some blood markers as well that are all being studied in various centers around the world. I'm going to switch gears a little bit and talk about ILD management for the last part of this talk. So a little bit of background. The objectives of therapy are obviously to improve how patients feel, function, or survive. And we make decisions on therapy mostly based on shortness of breath, pulmonary function tests, and imaging findings. Pulmonary function tests and imaging findings don't really matter to patients too much, but they do impact shortness of breath and cough and other things that do matter. And we balance these treatments, the benefits of these treatments, against the risks, which include side effects, commonly things like nausea, diarrhea, rash, and others. The dichotomy for the treatment of interstitial lung disease really is based on whether you have IPF or whether you have something else. And that something else being all of those other diagnoses that I mentioned before, things like autoimmune diseases and hypersensitivity pneumonitis and others. There's a long list over here, whereas IPF really is its own thing. IPF is characterized by fibrosis, whereas all the other ones, usually they start off with inflammation that then leads to fibrosis. And when we talk about treatment of IPF, we use an antifibrotic treatment. And these are the two antifibrotic medications in red here, nintedanib and pirfenidone. Whereas for all these other non-IPF disorders, we use immunosuppressive treatments, and that's a long list of all these ones in green down here. For IPF, these are the two big trials for idiopathic pulmonary fibrosis, looking at pirfenidone and nintedanib. And just to orient people quickly, this is looking at lung function over time. So this is your forced vital capacity, which is one of the common lung function measurements. And we start out at a patient's baseline. And over time, patients with IPF will get worse. This line declines over the span of 52 weeks, showing that these patients have lost a reasonable amount of lung function over that time. If we give patients pirfenidone, that line comes up to here, and we can see that patients have relative preservation of that lung function. So they don't decline quite as quickly as they otherwise would have. Pirfenidone and nintedanib seem to do the same kind of thing. They reduce the rate of progression by about half. So what about in other interstitial lung diseases? So again, I just showed you the evidence for antifibrotic therapy in IPF, but what about using antifibrotic therapy to target this downstream fibrosis in all of these other conditions? And there are a couple important studies that have been published in the last year that looked at that question. The first of this was looking at systemic sclerosis or scleroderma, and again, looking at nintedanib, which was one of those ones that I mentioned before for IPF. And to show you the same figure, patients with systemic sclerosis, they don't decline as quickly as they do if you have IPF, but you can see nintedanib also reduces the rate of progression by about 50%. In patients who are already on one of these anti-inflammatory or one of these immunosuppressive therapies, the benefit was a little bit more modest. So a lot of patients with scleroderma are on mycophenolate as their baseline therapy. Nintedanib didn't seem to have as much benefit if you were already on mycophenolate. So we're less likely to use both of these together, and mycophenolate remains the first line therapy for scleroderma. There's this other new entity. It's not a new entity, but it's a new way of describing this population of patients, which is progressive fibrosing interstitial lung disease. And there's a study looking at nintedanib in this group of patients that was published last fall that was very influential. So this was looking at patients, again, who do not have IPF. They had to have disease progression. They either had to have a lot of decline in their forced vital capacity or their lung function, or they had to have a more moderate decline in their forced vital capacity along with worsening symptoms or worsening CT scan findings. They did not allow patients to be on those immunosuppressive therapies. So people on mycophenolate, azathioprine, rituximab, and others were excluded. And what they did in this study was half of patients, actually a bit more than half, got nintedanib, and about 40% of patients got placebo. The population of patients that were enrolled in this, there was a lot of hypersensitivity pneumonitis, a lot of autoimmune disorders, as you can see here, about 20% of patients with unclassifiable interstitial lung disease as well. What we see with this, again, is that nintedanib reduced the rate of progression by about half. So similar to the other figures, patients on a placebo, which is basically like a sugar pill, they have a given decline in their lung function over the span of a year. The people who are on nintedanib had much less decline over time. So this again shows that nintedanib slows the rate of progression in patients who had progressive fibrosing interstitial lung disease. There's another study of pirfenidone in a similar population. These are patients with unclassifiable interstitial lung diseases who are also progressing. And this was a very similar design in many respects, although patients with mycophenolate were allowed into this study, which I'll come back to in a second. The problem with this study is that they tried to do something creative. And sometimes when you try to do something creative, it doesn't really work out. There were some problems with technical reliability and physiologically implausible values that they got when they were looking at the main endpoint that they looked at. And what they tried to do in this study was they tried to have patients do what's called home spirometry, where basically they're doing their pulmonary function tests at home. They do it every day, they get a few measurements, and then the study is based on what happens to those daily measurements over time. And we had things like this patient here had an improvement of 36,000 liters, 36 liters in their forced vital capacity over time. People's lung capacity or their forced vital capacity kind of tops out at 4 or 5 liters. So to have a 36 liter improvement, that's not possible. So there were some problems with the data here that basically made it so that patients, the data wasn't able to be analyzed properly for this study. And unfortunately, when that happens, the study actually is a negative study overall. If the authors of the study had just stuck to the conventional way of looking at things using site spirometry or the pulmonary function tests that are done in the hospitals that you guys are all familiar with, then they actually would have had a significant benefit, and we would be talking about this being a positive trial. So with a bit of a grain of salt, this ends up being a positive trial, even though the authors have to sell it as a negative study overall. So there was some benefit of pirfenidone in this population as well. In patients who were on mycophenolate, again, there didn't seem to be as much benefit. So pirfenidone seemed to help in this situation, but not as much if you were already on mycophenolate. So again, we're less likely to combine both of those. And a lot of these patients, mycophenolate would still be their first medication of choice. And pirfenidone you would think of as an add-on only if you're failing mycophenolate. So what's next? So for the nintedanib in progressive fibrosing interstitial lung diseases, this is a very common question that I get asked by patients and other physicians. Can we get access to this medication now for these patients? So nintedanib is approved in Canada for idiopathic pulmonary fibrosis, and it's funded in all the provinces as well if you meet specific criteria. But one of those criteria is that you have to have IPF. So if you have a progressive fibrosing interstitial lung disease of a different subtype, so a non-IPF diagnosis, at the moment, Health Canada has approved nintedanib for that purpose for those patients. The provinces have not yet decided whether to provide funding for that medication, for that indication at this point. So Health Canada has approved it, but the funding by drug plans and by the provinces is not really clear at this point. There's this middle step that's currently ongoing, what's called a CADTH Common Drug Review, and there's a committee that has to weigh the clinical, economic, and benefit of this drug in this indication, and then they will provide some reimbursement recommendations to the provinces and to other drug plans, and that's an ongoing thing right now. So at the moment, nintedanib is available. It's got a Health Canada approval, but it's not yet funded, and so it's not yet accessible. And it's a very expensive medication at this point. So a few take-home points to close up. So interstitial lung disease, the diagnosis remains challenging, even for expert groups. There's several potential strategies that we're studying and that we're implementing to improve diagnostic accuracy. Having said that, diagnostic uncertainty is common. There are genetic and other biomarkers that are not quite ready for us to use to address this uncertainty. There are new guidelines that have just arrived for hypersensitivity pneumonitis that will help standardize that diagnosis. Pirfenidone and nintedanib, they both have benefit in terms of slowing the progression of mild to moderate IPF by about 50%, and both have benefit in patients with other interstitial lung disease subtypes as well. We still need more effective and better tolerated treatment options, however. There are many experimental therapies that are currently being developed and are under evaluation right now. However, with COVID putting a bit of a wrinkle into all of this that Dr. Wong will talk about in a minute. There are also some non-pharmacologic therapies that we need to consider in every patient. I haven't talked about that very much because there hasn't been a lot of new evidence in that area this past year, but these are as important and sometimes more important than the medications as well. There's some guidelines coming for oxygen use in chronic lung diseases, including in interstitial lung disease, and those will probably be available within the next couple of months. And hopefully that will standardize some of that as well in British Columbia, as well as across Canada and elsewhere. So with that, I think we're actually going to hold questions for the moment, and I'm going to ask Dr. Wilcox to triage questions from everybody when we come to that portion of this session. And at this point, I'm going to stop and hand over to Dr. Wong. So Dr. Wong is a relatively new recruit to our group at St. Paul's Hospital in Vancouver. She's highly trained. She's done all of her medical training in Canada and recently finished an interstitial lung disease fellowship with us as well. Has a very active and very rapidly growing research career ahead of her as well. And she's going to talk to us largely about COVID in interstitial lung disease, which is obviously a very hot topic that we get a lot of questions about these days. So with that, I'll turn it over to Dr. Wong.
Okay, thank you, Dr. Ryerson. I just want to confirm that my slides are showing up all right before I begin. Perfect. So thank you very much for having me back this year. It's hard to imagine that we were all together in a hotel conference room a year ago, but it's great to see how we've adapted with the required change. So topically, I'm going to be speaking about pulmonary fibrosis and COVID-19. And quick disclosure slide. So let's begin with a bit of background on COVID. COVID is caused by the SARS-CoV-2 virus. And when someone becomes ill, that's when we say that they have COVID-19, which is the disease. SARS-CoV-2 belongs to the family of coronaviruses, and there are hundreds of different coronaviruses. Currently, we know of 7 that can infect humans. So here we see that in the top left, for example, one of the coronaviruses causes a common cold. Another coronavirus caused the SARS outbreak in 2002, and so forth. The way that COVID-19 is spread is mainly through respiratory droplets. So when someone is infected and they speak or cough, some of those droplets get released and someone can then inhale them or touch them on a contaminated surface. The challenge with this virus is that people can be asymptomatic when they are infected with the virus. So they could inadvertently be spreading the virus without knowing. Now, when people present with symptoms, typically it's a flu-like illness, so things like fever, cough, shortness of breath, and fatigue. And outlined here are the common symptoms that I just went through. However, people can develop severe illness where their lungs get more affected, they become more short of breath, they may need to be hospitalized because they need oxygen. And then COVID really affects the patient from head to toe. And what we know is that COVID can affect the heart. It could also cause injury to the liver and kidneys, for example. An interesting question that I've gotten recently is, why is there so much attention given to COVID? And I think there are a lot of different reasons, but this table helps to demonstrate some of the differences between COVID and influenza, for example, which we get every year, the common flu, and then compared to other coronaviruses on the right-hand side. So we've got SARS here, and then MERS, which is the Middle Eastern Respiratory Syndrome. So if we look at these red boxes, what we see is that COVID-19 has a faster and higher transmission rate. So this R0 number is the reproductive number. And that tells us how many people will get infected when they come into contact with one person who has the virus. So with the flu and the influenza virus, if I was infected, I, on average, would infect one other person. On the other hand, if I had COVID, I would infect up to 2 to 3 other people. The other difference is that there's a much higher fatality rate with COVID. So out of all the people who are infected, what percentage succumb to the disease? And with COVID, it's over 3%, whereas with the flu, it's 0.1% at most. The other thing is that I think that the global burden of disease is much higher with COVID. So yes, the flu, more people get infected with it. So about 1 billion people every year around the world have the flu. And currently we're at about 30 million people with COVID. But the number of deaths is much higher with COVID. So with the flu, the annual death rate in the United States was 10 to 60,000 per year. Currently, we're at about 196,000 in the United States, and that number is ongoing. And then when we compare it to the other coronaviruses, yes, SARS and MERS had a higher fatality rate, but the total number of cases and burden around the world is lower compared to COVID. So those are some of the differences between these different viruses. And then why are we interested in COVID specifically for patients with interstitial lung disease? Well, the first point is that patients with ILD have risk factors for serious COVID-19 illness. So if they became infected, they have risk factors for requiring hospitalization and oxygen use. And some of these risk factors include being of an older age and having other health problems, which include lung diseases like interstitial lung disease, having a weakened immune system, other medical conditions such as high blood pressure or diabetes. And then the second thing is we know from recent studies with COVID, as well as with past coronavirus outbreak studies, that there are long-term respiratory outcomes after someone becomes infected with a coronavirus. So Dr. Ryerson and I published a paper recently looking at a cohort of patients with COVID. And what we found was that 3 months after they developed symptoms, they still had cough and shortness of breath in 20% of patients. They also had reduced lung function. And then from past coronavirus studies, we know that people have long-term lower exercise capacity. There's a lot of psychological side effects or sequelae. So they end up having persistent anxiety and depression. And then all of this together lowers people's quality of life. This is a study that highlights some of the previous points. So this was a study that followed patients who had SARS, which was a different type of coronavirus, and they followed them for a year after their infection. And then they did breathing tests at 3, 6, and 12 months. And what they found was that at 1 year, after their symptom onset and after they had a lot of time to recover, 25% of patients still had abnormal lung function. And I think the striking thing about this is that if we look at patients who had their breathing tests at 3 months, about 5% of people had abnormal lung function, but this number rose over time. So someone could have normal lung function, but then later on go on to develop abnormalities. This is a graph that shows the daily case counts of COVID in British Columbia. And in BC, we had our first confirmed case at the end of January. And then we saw our first wave in March. And this is the time where we start to notice more patients getting hospitalized and discharged. And the challenge with COVID has really been the uncertainty with the disease. And so questions like, when is the next wave going to happen? How many people should we expect in hospital, and how can we plan for those resources? What should patients who have COVID expect in their recovery? We didn't have the answers to a lot of questions, and so we did a few things to try to help address this. The first thing we did was at St. Paul's and VGH, which are 2 hospitals in Vancouver, we created a post-COVID-19 respiratory clinic. And this was to allow follow-up of patients after they were hospitalized with COVID. And then it also allowed us to establish a registry of patients so that we can help to address some of these research questions. The other thing that we did was that we published a paper highlighting some of the modifications that will be required for the diagnosis and treatment of ILD. And Dr. Ryerson and I were able to work with other ILD doctors across Canada, and we wrote this paper and published it a few months ago. So for the rest of the talk, I'll be highlighting some points from this study. If you're interested in reading it, I believe it's accessible, so you could just Google the title and it should come up. Of course, it is meant for a medical audience, so there's some medical jargon in there. So let's talk about diagnosis and how that's been impacted during COVID. This is a very simplistic way to represent how we diagnose ILD, and this is how we usually do it before COVID. So when we suspect someone of having ILD, we see them in clinic face-to-face, and then we perform our history or physical exam, get all the necessary information, and then we complete their workups. So that will include blood work, the CT of their chest, and then the breathing tests. And then, like Dr. Ryerson mentioned, sometimes we need to discuss complex cases in the multidisciplinary discussion. Some people will require a bronchoscopy, others will require a surgical lung biopsy. But ultimately, our goal is to come up with the most accurate diagnosis possible. And with the multidisciplinary discussion, Dr. Ryerson highlighted this, that it's really the collective coming together of ILD experts in terms of clinicians, radiologists, and pathologists, so that we could really improve our confidence in diagnosis. And as a result, because we're more confident in our diagnoses, that helps to avoid the need for invasive procedures like the surgical lung biopsy. So this is an adapted figure from our manuscript. On the left-hand side is the previous simplified ILD diagnosis approach. And then on the right-hand side in the blue boxes, we've outlined some things to consider in terms of modifying the diagnostic approach during COVID. The important thing to note is that these modifications are going to change depending on the case counts in the community. It will also depend on which community you're in and how severe COVID is. So at the time that we wrote this paper, we were going through the first wave. The hospital had shut down elective procedures. And so those modifications may not be applicable right now, where some of the things have opened up since. But nonetheless, it's important to go through these things and think about. So with the clinical evaluation, we are still trying to minimize in-person contact as much as possible. And so this would include doing consults or clinic visits through video conferencing or telephone. We still encourage that the workup of ILD still be completed, so still getting the blood work and the CT tests. With the breathing tests, that kind of depends with how severe COVID is in your community. But with the breathing test, they do generate aerosols. So you can, if you remember going through the testing, you have to do all these forced exhalation maneuvers. It might cause a cough. And so there's increased risk of possible transmission. And then with the multidisciplinary discussion, this is currently being held virtually in British Columbia. And as Dr. Ryerson mentioned, sometimes our diagnostic certainty may need to be a bit lower than previous because we don't have all the pieces of the puzzle. And then for the bronchoscopy and lung biopsy, right now we are doing them, but I think we still have some hesitation and really are only doing these procedures if absolutely needed and if they're going to change your management. And then lastly, it's important to remember that as COVID hopefully settles down, that we revisit patients who don't have as confident of a diagnosis and get those missing puzzle pieces. So to summarize the diagnosis, the assessments and testing, they've been modified really to try to minimize the risk of COVID transmission. And then these modifications are dynamic and they're going to change day to day, week to week, depending on what the community rates of COVID are. But what will remain constant is that we will always strive for an accurate ILD diagnosis, but we just have to make sure that we're doing this in a safe fashion. So let's switch gears to treatment. To start, this is a figure showing how fibrosis in the lung develops. So at the end of our breathing tubes, we have these structures called alveoli, or in this case, it's an alveolus. And this is where the exchange of oxygen happens. So you can imagine you're breathing in oxygen, it crosses this alveolus and goes into the bloodstream, which is this vessel. With interstitial lung disease, there's some kind of damage or injury to the alveolar lining. And then as a response to that damage, the body tries to repair it. But there's an abnormal repair and it gets a little over exaggerated and it develops and it lays down too much tissue. And so it forms a scar. And you can imagine that the oxygen then has to try to cross this thickened tissue. So with interstitial lung disease, some examples of injury include if you have a connective tissue disease, then your body's generating proteins in the body that are kind of causing inflammation or damage to the lung. And then with hypersensitivity pneumonitis, you're inhaling something that is causing some kind of insult. Knowing this, we have a few targets for our therapies. So we can try to dampen the injury and then we can also try to dampen the response to that injury. So that's what we call immunomodulators, or what Dr. Ryerson was calling immunosuppressive therapies, where we're trying to quiet down the immune system a little bit. And then we've got the antifibrotic therapies, where we want to try to minimize as much of that scar tissue as possible. So these are some of the common immunomodulators and antifibrotic therapies. So starting with the immunomodulators, the big question is, we're suppressing the immune system by using these medications. Does that put people at increased risk of developing COVID? And Currently, it does not appear that patients are at increased risk of severe illness, and this is based on previous coronavirus outbreaks, looking at patients who were on this medication, and then also some of the recent data that I will show you at the end. Now, the only thing is with prednisone, there was one study that showed that patients who were on prednisone long-term had slightly higher viral loads or the number of viruses detected in their body compared to people who weren't on prednisone. So, you know, does prednisone lead to possibly more virus developing within the body and replicating? I think the challenge with this study was that, one, it was very small, and so it may not represent the entire patient population, and we can't generalize those findings. The second thing is there were other studies that didn't find these results. And then the third thing I'll say is that just because someone has higher viral loads, we don't know if that equates to someone being more sick. So I think the verdict is still out on prednisone, and further research is going to be needed. So this is how I kind of think about immunomodulators in our current COVID era. So if there's a patient who we're not suspicious of having COVID, then we will continue to use these immunomodulatory therapies if there's an indication. Now, we may be a bit more hesitant with using steroids. Maybe we'll start at a lower dose, or we'll use an alternative drug. If there's a patient who we're suspicious has COVID or they're confirmed COVID positive, then we will not initiate these medications because we want to allow their immune system to deal with this virus. And then if patients are already on the drug and they develop COVID, we may reduce the dose of the drug, but it's also important to not cut these drugs out cold turkey because that could lead to rebound of the underlying interstitial lung disease or other condition that they're being treated for. And then with the antifibrotics, there's no evidence that antifibrotics increase the risk or the severity of COVID. So we're continuing to prescribe nintedanib and pirfenidone as usual. And then we also have to make sure that patients are willing to still get the blood work and be monitored for side effects. So switching to medication monitoring, one of the challenges with the immunomodulatory therapies as well as antifibrotics is that the side effects can overlap with how patients present with COVID. So this is a table outlining some of the side effects with mycophenolate or azathioprine, which are common immunomodulatory therapies. And we see that they can lead to gut upset, so diarrhea, nausea, stomach pains, and that can occur in just about under 10% of patients with COVID when they're presenting. And then these medications can lead to bone marrow suppression. So on blood work, they'll lower your blood counts. And then up to 30% of patients with COVID will have a reduced blood count as well. And then these therapies can also irritate the liver and cause inflammation. So with the blood tests, that'll increase the liver enzymes. And similarly with COVID, it can also increase the liver enzymes. With the antifibrotics, they have similar side effects. So the gut upset and liver inflammation. And then with nintedanib, there is a very small chance of blood clots. And then with patients who have COVID, we've found that they tend to actually have blood clots as well, about 7%. The other thing I will mention is that ILD treatment is not just about the medications. And so there are many other important aspects of ILD care that have been impacted by COVID. So the first is exercise, and people's routine have all been kind of shifted and changed because of COVID, but it's really important to continue to exercise. Also treating other medical conditions, so reflux and sleep apnea, for example. Evaluating patients for whether they need home oxygen and then making sure that they get it during COVID, as well as making sure patients are still have that psychological and social support in place, because mental health, we know, will impact physical health as well. And then lastly, involvement in research. So research has really been impacted by COVID. Initially, we weren't able to bring patients into hospital and get the required testing done. We weren't able to enroll new patients in clinical trials. And this negatively impacts patients because they don't have access to drugs that are not available to the general population. So I'll end with a study that was just published over a week ago, excuse me. And it was looking specifically at patients with interstitial lung disease who had COVID. So this study looked at patients between the months of March and June of this year, and they were collected from 6 hospitals in Boston in the States. And what they did was they found 306 patients in this window. 46 of those patients had COVID. And so they compared those 46 patients with others who didn't have ILD but had COVID to see if there were differences in outcomes. And this is a table of some of the results that they found. So on the left-hand column, we have patients who had ILD, the 46, and then the other column is patients who didn't have ILD but had COVID. And they ensured that both groups were of similar age, sex, and race, so that we know that these factors aren't the reasons for some of the differences that they saw. So in the red boxes, those are kind of the important findings. The first thing that they noted was that patients who had ILD were more likely to require hospitalization. So 74% of patients with ILD who got COVID needed to go into hospital. Whereas people who didn't have ILD, only 58% required hospital stay. The other striking thing was that only 50% of patients with ILD were able to be discharged from hospital, compared to 85% of those who didn't have ILD. And this is probably due to the fact that the death rate was much higher for patients who had ILD. So about 1/3 of that cohort of patients actually passed away from the disease, and compared to 13% of patients who didn't have ILD. So this equates to patients who have ILD who developed COVID had a 4 times the likelihood of succumbing to either their ILD or the virus or consequences of having the virus compared to patients who didn't have ILD. The other important findings from the study are that first, they looked at patients who were on steroids and immunosuppression as well as antifibrotics, and these medications didn't have an effect on the likelihood of death, which is reassuring for us when we're prescribing these medications. Now, this study wasn't perfect and there were some limitations. First, it was a small sample size, so we know it was only 46 patients with ILD. And then the second thing is we don't really know what the distribution of the ILD subtypes were. So was the ILD cohort mainly a group of patients who had an ILD that tends to have a worse survival? And so that's why we saw a higher mortality rate. So to conclude for my portion of the talk, I think it's important that we find the right balance between providing the ILD care and trying to minimize the risk of getting COVID, and that knowing that these modifications are dynamic and we have to be adaptable with how COVID is playing out in the community. The last thing is that we all know we're in this new normal, but there can be some negative consequences to this new normal in terms of how it impacts patients with ILD. So for example, I've noticed that people's routines are kind of, they've been uplifted. Maybe they're not exercising as much because they're not going out for walks. They don't want to be exposed to COVID. They're not grocery shopping. They're not doing their usual activities that keep them active. And as a result, people are becoming more sedentary. They're getting more deconditioned, and that can increase the sensation of shortness of breath, for example. So I think it's important to reflect on how this new normal is impacting your disease, and then trying to be proactive about coming up with ways that we can try to counteract those negative consequences. So with that, I will end, and I will hand it back over to, I think, Dr. Ryerson.
Great. Thank you, Alyson. That was fantastic. So at this point, we've purposely left a lot of time for questions for Dr. Wong, myself, and Dr. Wilcox to weigh in on. So I think what I'll do, we'll have Dr. Wilcox, ideally we can turn on our videos, and I think I'm going to ask that the other people on this keep your video off for the moment, just to minimize distractions. So anybody else on the call, we'll just have Dr. Wong, myself, and Dr. Wilcox with their videos on, and we'll call on other people as well if there are additional questions for some of the other panel members here. So Dr. Wilcox has a series of questions that have been provided to him by patients who registered beforehand, and also that have come up during the talks as well. And maybe before we get to those questions, I'll introduce Dr. Wilcox very quickly. Dr. Wilcox is one of my colleagues and Dr. Wong's colleagues at St. Paul's Hospital in Vancouver. He comes to us with a wealth of experience in interstitial lung diseases, as well as really every other pulmonary disease that you can think of. And so he's one of our senior colleagues who's provided a lot of mentorship to a lot of us over the years. And he's going to help us kind of work our way through all of the questions that have been posed to us so far today.
Hey, thanks very much, Chris. Am I coming through?
Yep.
Okay, great. I don't think it's any surprise to anyone that there are many questions that come up related to conditions as heterogeneous as interstitial lung disease. And there's many areas that we address where we do have evidence, but from the literature, but a lot of areas where we don't really have solid evidence, and that evidence that's there may be evolving. So it's a natural situation for having questions. And I want to thank those of you that did advance some questions prior to this, and I know that there's other questions that have come up. We won't have time to necessarily go over all of those, but I think what we'll try to do is endeavor those that we don't address that we'll respond to separately as well. And I'm going to take the moderator's prerogative here to go around and partition some of these questions to some of my co-presenters, Dr. Wong and Dr. Ryerson. So without any particular ranking in terms of importance or timing, I'm going to address the first question to Dr. Ryerson, and that's more along the lines of a why me? Why did I get this condition? And this is more specific, I think, to idiopathic pulmonary fibrosis, and it relates, I guess, more generally to, are there modifiable risk factors for the future that we might be able to identify that to make it less likely individuals will get this moving forward? So Chris, if you could address that.
Sure, I'll start tackling that, and happy to have either you or Alyson weigh in on this as well after I give it a go. So first question, why me? So that's a difficult question, and a lot of the time it really comes down to having bad luck. But to put it a little bit more scientifically, we think about interstitial lung disease predominantly as being an interaction between your genetics and your environment. And that really goes for pretty much any disease. It's always an interaction between any genetic predisposition as well as your environment. So what types of exposures you may have had over your life. The challenge with interstitial lung disease is that because there are so many of these, the specific genetics and the specific exposures in your environment are so varied, and there's so many different ways that you can get to a final common pathway of interstitial lung disease that it's really difficult to pin down one specific answer to this. We know from some recent studies that there are certain genetic variants that predispose to interstitial lung disease. One of those, as an example, is MUC5B, which is a very common variant. You see it in up to 10% of healthy people, and you see it in about 40% of patients who have IPF, and similarly, fairly high proportions of patients who have other types of interstitial lung disease as well. It's so common that obviously not 10% of the patients of people are getting interstitial lung disease. So even though 10% of people have that variant, they're not all getting interstitial lung disease. So there's something else that goes into why do some of those patients end up getting interstitial lung disease. And for IPF, one of the examples would be being an older man is a risk factor. Having a history of smoking would be a risk factor, and having a risk of aspiration or acid reflux would be a risk factor as well. When you put all those things together, possibly with some additional genetic variants that we haven't identified yet or that we're just starting to learn about now, that's the combination of things that leads to that diagnosis often. Having said that, you can still get that without having any of those risk factors. It's much less common, but it's still possible. And there are probably additional genetic risk factors or other environmental risk factors that we haven't really learned about yet. If you think about other diagnoses, so hypersensitivity pneumonitis as an example, that's related to an exposure, often things like living with a bird, a pet bird, living in a house that's had a significant amount of mold in the past, living on a farm or working on a farm where there's a lot of moldy hay. Those types of exposures also can lead to hypersensitivity pneumonitis, which is one of those other common interstitial lung disease subtypes. Again, not everybody who lives with a bird gets hypersensitivity pneumonitis, and not everybody that had mold in their home gets HP. So there's, again, some other reason that that person's immune system was triggered to act in a dysfunctional or a harmful way. And that, again, probably comes back to your genetics or maybe to some other exposures when you were younger that may have primed your immune system to go down that path. There are lots of other examples about autoimmune diseases and other occupational exposures to asbestos or silica or coal. And so the list can go on, but those are a couple examples of how that can happen. The other question is about modifiable risk factors. So obviously your genetics, maybe 100 years from now, we'll have some ability to modify our genetics and those types of risk factors. But right now, that's not something that we can do. So the risk factors that we can modify really are those exposures. Cigarette smoking is the big one. There's not really many good reasons to take up smoking. And if you have a family history of this, smoking is really not a good idea. There are other risk factors related to occupations, pet birds, and I know pet birds are a thing that are they're very important to some people, but if you have a genetic predisposition and you put that with a pet bird, that's a risk factor. And so some of those things are modifiable. Some of those things are maybe less modifiable than others or more challenging to modify, but those are some of the things that you can potentially impact.
Well, thanks so much, very much, Chris. I think that's a pretty comprehensive answer. Alyson, do you have anything further to add? Okay.
No, that was very thorough.
Okay, good. I'm going to move to the next question and pose this to Alyson, and it relates a little bit more to some of the oral antifibrotic therapy possibilities. And the broad question was, with all the possible side effects, is it really worthwhile to go on to one of these newer antifibrotic medications?
So it's a great question. The first thing is that we know that the treatments, they're not curative. So from the studies that Dr. Ryerson presented, we saw that they slow disease progression, but they don't necessarily, well, they don't cure the disease. So it comes down to, patient preference and whether they're willing to try the medication and possibly run into some side effects. Now, although I talked a lot about side effects, these are things that are very manageable. We're comfortable with these medications. There's things that we can do to address the side effects. And then the other thing is, worst case scenario, if we can't, we stop the drug and those side effects typically go away. So I try to encourage patients to at least try the antifibrotics because we can manage most of the side effects. And then that way we, can potentially have that benefit of slowing your disease. But if we never try it, we'll never know.
One thing I'll add to that, if I can, is that in IPF in particular, the vast majority of patients with IPF will either need a transplant or will pass away from IPF. And so even though some of the medications come with side effects, or at least some patients get side effects, slowing down the disease progression can still have a very big impact on overall prognosis in terms of survival. So it becomes a balance of whether you're willing to trade that type of benefit with side effects. And hopefully you don't have any side effects, and there are a substantial percentage of patients that don't. But if you do have side effects, then that's a decision that we have to balance.
I think with a lot of therapies, there does tend to be the focus on the downsides, the adverse effects that come out. You know, as you've heard, that does occur a lot of the times, not invariably, and a lot of times these are fairly reasonably managed adverse effects. So you're always, you know, weighing it in the cost-benefit analysis. So, and the options otherwise, particularly in IPF, are pretty limited. So, you know, I think that's be aware of the side effects, how to deal with them, being upfront and being prepared is crucial. But you know, I think that most of the times these are manageable. I just wanted to stay on the theme of medications here and pose this to Alyson and Chris. It relates to the newer developments in the science, but specifically not so much new medications, but Pirfenidone and nintedanib, but new ways that they might be delivered to the individual. You know, getting around some of these side effects potentially. If you could deliver them directly to the lung, much like we do like an asthma or COPD inhaler therapy or some of the other medications that we use in other diseases, if we could get them down into the lung with that route and not necessarily use them systemically, you know, you might have less side effects anyways. But they're not out there. This is not ready for prime time, but do Dr. Wong or Dr. Ryerson have any comments about the potential for inhaled route for these currently oral antifibrotic therapies?
Go ahead, Alyson.
Sure. Just as a simple background, this inhaled therapy, there are studies looking at both Pirfenidone and nintedanib being inhaled. So what that looks like is someone has a mist and they inhale it, and then that helps to deliver it directly to the lungs. And the reason companies are looking into this is to try to help minimize side effects, because less of it gets absorbed into the rest of the circulation. I think it's, you know, it's exciting, and especially for patients who, let's say they start on the oral therapy and then maybe we can't manage their side effects. Well, let's switch them over to a different modality of delivery. It's definitely not ready for prime time. Currently, Pirfenidone just published their phase 1 study results. So there's 3 phases when drugs are being developed. Phase 1 is basically just trying to come up with a safe dose to go on to the next phase. So that one's been published, and they found that there was a safe dose from that study. And then with nintedanib, they are currently just in animal model phases. So I think there was a publication in a rat model that looked like there was some positive results. So now that there's positive results, they're going to probably move on to human, trying it in humans.
Okay. Chris, anything further to add on there?
That was perfect.
Yeah, exciting potential, but a long way from clinical practice. We shall see. The next topic I'm going to take on, and that relates broadly to the role of supplemental oxygen in interstitial lung disease. And one of the questions was specifically, I'm short of breath with my my interstitial lung disease. Should I be on oxygen at home? And then some of the other questions relate to more of the practicalities or the logistics of it. I guess the first step is the question of why am I short of breath with interstitial lung disease? And there's no question if the oxygen levels do drop enough in the body, not just in ILD, but in any condition, then shortness of breath will occur. So that's there and a given. And obviously shortness of breath is to be expected in virtually all patients with ILD. But it turns out that there are other very important mechanisms and explanations for breathlessness in ILD. And in many respects, they may be more common even than the component that's explained by low oxygen. And can be things like we've heard alluded to. Some of the responses to being short of breath is to sometimes be less active physically, and that can even compound the perception of shortness of breath. But very often, this being aware of shortness of breath really relates to the increase in work of breathing. And when you have fibrosis in your lungs, inflammation, but particularly fibrosis, that stiffens the lungs. And we have a certain term for that. It alters the compliance. So those stiffer lungs is just more work to expand those lungs, more work to get the effort to get air in and allow the oxygen to transmit. So the oxygen may actually be okay or adequate, but that extra work, particularly with exercise, leads to this awareness of the breathlessness. And obviously that wouldn't necessarily be improved by oxygen. So, is there a role? And when in the correct situation, extra oxygen can be important. It can improve symptoms. It can lessen the breathlessness. It can lead to better exercise capacity. And over the long term, if the oxygen is low enough, it can actually have very important effects. It can lessen the strain on part of the heart, the right heart that pumps blood through the lungs, and by reducing that, it could actually have some improvement on long-term outcomes and even survival. One of the questions related to I guess, transient or very short-term desaturations, dropping below 88%, just as one question. And it turns out the body, has a lot of adaptations that it can handle short-term desaturations without really being a major concern or a major danger. So it's not so much that very short-term issues. It's the bigger risks are for the longer term implications. But how do we test for that? And really what we've been using and the recommendations and the restrictions, I guess, that have been out there for supplemental oxygen they've been extrapolated from other diseases, particularly COPD. And there are reasons where there may be some commonalities and we might be able to use the same rules of COPD, but there are reasons to think as well that could be different, and hence I look forward to the new guidelines that are coming out that may suggest there's a little bit more, specific customization of these rules for interstitial lung disease. But currently, in British Columbia and most provinces, there are rules that have been established that relate to the access of oxygen at home. And there's certain levels, I won't go into all those, I don't think that's really overly helpful, but there's certain levels that one has to show and testing, and it's specific testing for this, low levels for continuous oxygen, and that's generally in the range of less than 88% of saturation. Their blood gases, their measurements there. There are separate rules for, and I would say somewhat changing rules for oxygen just in the setting of exercise or with activities, and then separate rules for oxygen overnight. And these are certain levels, and it really requires a formal testing through a laboratory, certainly in BC, and you have to fulfill those levels of reduction. And just an example, to get portable oxygen with activity approved in British Columbia, you have to have a drop in oxygen saturations down to below 88%. But you also, with oxygen, have to actually have an improvement, a significant improvement in the walk distance over this 6-minute test. So there's a double requirement there. And I think it's, reasonable to have restrictions to make sure oxygen is appropriately used. There's certain costs to it, and we want to be sure that we're employing it when it's going to make the most difference, because in many instances, as I said, the effort of breathing is really what's driving the breathlessness, and that would not necessarily be changed by extra oxygen. But there are some challenges in monitoring that, particularly in scleroderma, using the pulse oximetry. That little finger probe may be very inaccurate because of the problems with perfusion. In other forms of ILD, not so much an issue. But monitoring that and thinking, am I anywhere near that level at home? It's relevant, and a question came up around this about some of the newer technologies that are out there. And I think Apple just announced earlier this week its latest generation Apple Watch. And amazingly, the higher end version anyways will have a built-in ability to monitor oxygen saturation using some of the applications of the technology that we use in our laboratory. It'd be very exciting to see that, the accuracy. I think it's too early to tell, but it just shows you how rapidly technology is evolving, at least in the monitoring, and I suspect we will be doing that in our patients in home, and a lot more than we did previously. The final question related to oxygen comes to the practicalities. If you are on oxygen, and you're all aware that there's various devices that can be used. The first generation, earlier generations, challenging in terms of portability, but these portable oxygen concentrators that are available now have really changed the ambulatory oxygen use. They're just able to provide a longer duration of use. Now, the downside, though, is that there's a certain limit to what can be achieved in the supplemental oxygen flows. And most of those have been up around 3 liters per minute. And as one advances with interstitial lung disease, that 3 liters per minute may not be enough to achieve what we would target to try and get in terms of oxygen saturation. So the question related to, what are the developments there? And like all, technologies, there are improvements, and the portable oxygen concentrators, the latest iterations are able to go up to 5 liters per minute, and we hope to have those more broadly available. And that will cover, I think, the majority, not all. Some patients still require an even higher flow rate, but I think we will see technologies that enable those portable concentrators to not only get smaller, to have better battery life, but also to have higher flow rates. So a lot there on oxygen, but still an important part of, at least with the more advanced management of this condition. Take a breath there, and then I'm going to move to our next question. And in some respects, I would say, Chris, one of the more challenging questions related to this. But what does having IPF mean to my future?
So it's very difficult to answer that with a single blanket statement. So it'll be a little bit of a long-winded answer. So IPF, or idiopathic pulmonary fibrosis, as I mentioned, this is one of those specific subtypes of interstitial lung disease. So we're talking about one of those 200 things. If you're not sure that you have IPF, it's worth talking to your doctor and finding out exactly what diagnosis you do have. It's also specifically important to note that pulmonary fibrosis doesn't mean idiopathic pulmonary fibrosis. So whatever we say about IPF applies to IPF. It doesn't apply to other subtypes of pulmonary fibrosis. So historically, IPF, what we know from the literature in the past, this is going back a decade or more, the average survival with IPF was about 3 years from the time of diagnosis. So that's a short time, and that's what the literature would suggest from studies published 10, 20, 30 years ago. That's an average, and it's important to recognize that an average is really just that. So half of people are less than that, half of people are longer than that, and there are some people who are quite a bit longer than that. It's also important to note that IPF is very unpredictable. So sometimes it can be slow to start and then sometimes speed up, and sometimes it can speed up and then stabilize. So we don't have a great ability to predict who is going to do what once they've been given that diagnosis of IPF. We do know some things. If you're diagnosed at an earlier stage, that's better. If you're a woman, that's better than being a man. If you're younger, that's better than being older. But we don't have a great ability to predict things. We also know from the last decade or so that things have changed quite a bit in terms of the overall prognosis of IPF. And we're at the point where we don't have great numbers from the last few years, just because we haven't had enough time to see how people are doing now. There have been two major developments that have changed our outlook on IPF to a large extent. One of those is a study that I didn't talk about that was published in 2012. And this was what's called the PANTHER trial. And that study looked at the combination of prednisone, azathioprine, and acetylcysteine in patients with IPF. Prednisone and azathioprine are both immune suppressant medications, and historically it was thought that those were good treatments for IPF. What the PANTHER study showed us is the exact opposite, that those were very harmful treatments of IPF, harmful to the point where people were dying at a much higher rate if you were given those medications than if you were not. So since 2012, and even a little bit before that in many places, we weren't using those types of medications for treatment of IPF. But that 3-year survival that I quoted was based on a time when we were using that medication combination pretty frequently and probably causing some harm to those people who were getting it. The other big development, obviously, is those two antifibrotic medications that we mentioned recently, Pirfenidone and nintedanib. And by slowing the rate of progression by half, those will also be increasing the survival. Those medications have only been around since about 2015. So we really just haven't had enough time to see the full impact of those medications in the overall disease trajectory. But we expect that at a minimum, IPF, we're looking at averages of 5 or 6 years at this point, and maybe longer in some people who respond really well to those medications. The last thing that I'll say is that lung transplant is much more common now than it was 5, 10, 15 years ago. And we're also able to transplant patients who are older or who have other medical issues that previously would have prohibited those transplants from happening. So that provides an additional way that patients are able to live a longer life and with better quality of life as well. So I would say that having IPF, it's not a good thing. You'd much rather not have IPF, but there have been some advances. And so some of what you will read online is frankly quite a bit out of date at this point, and it's better to talk to your doctor about your specific situation.
Great. I'm going to move, thanks, Chris. That was a terrific way of dealing with, a question I think is there in a lot of people's minds, but a lot of people are somewhat reluctant to bring up. Alyson, will it harm my lungs to exercise with interstitial lung disease? Kind of alluding in a little bit into pulmonary rehab as well.
Yeah, so I think you kind of alluded to this with your response to oxygen, but it kind of goes along with that adage of use it or lose it. So with exercise, we've studied it in patients with ILD and compared it to patients who weren't in an exercise program. And studies like that have found that people have increased exercise capacity when they're part of this exercise program. And then their quality of life is also improved. So those are things that are really important to patients, and that's why we encourage as much exercise as you're able to do. The other thing I think that's obviously harder to demonstrate in a study is that I think patients have a better sense of their shortness of breath and awareness of their disease when they exercise regularly. So you can imagine that if you're exercising regularly, you're getting short of breath, you can differentiate normal shortness of breath from abnormal shortness of breath. And so that in a way gives you a bit more control over your disease. So I think that's another added benefit to exercise, and definitely would encourage that.
Great, I like that. Use it or lose it, and I think that's a good thing to keep in mind when it applies to anything, but exercise particularly. I'm going to take on the next question that extends a bit from what Chris already led into, is about transplantation. The specific question: I'm 68 years old and my ILD is getting worse. Would I be considered for lung transplant? And you know, we've seen the newer therapies that are out there that definitely can slow disease progression, but we're not yet in a position where we have anything that can completely ablate progression, at least in all people. So the reality is that, particularly with idiopathic pulmonary fibrosis, with more advanced disease, there may not be too many other options than to consider lung transplantation. The timing of when you propose for lung transplant, you know, is something that ILD, you know, experts are very aware. There's a lot of discussions with that, and there are certain thresholds that would lead one to propose the time for at least evaluation of transplantation. It obviously can take a long time from the start of that to actually getting transplanted. So you don't want to leave it too late, but that's a whole topic in and of itself, and I won't get into that. Suffice to say that it might be considered maybe a little bit earlier when transplant comes up than some other respiratory diseases in terms of the numbers we have for lung function testing. That's because it's sometimes a little bit difficult to predict how this disease trajectory is going to be. But the transplant realities, and I bring those up, there are some realities. The realities are that the results can be very good and often are very good, but not invariably. And there still are the numbers of 5-year survival that are out there. They have improved over time, but they're still more in the range of 50 to 60%. The chronic rejection issue just unfortunately has yet to be solved, and whether it can be, you know, it remains a challenge. The outcomes earlier on around surgery and early rejection management have been where the real benefits and improvements have been achieved. But there is that. So, you know, not everybody does really well for the long term. And then there's the other harsh reality is that there just aren't enough lungs that are available really to go around to meet the needs of all the individuals, ILD or not, that are out there. And thus, the transplant team have some very difficult decisions. In a sense, they're having to decide to take these lungs and to provide them to the individuals who have the best likelihood of better outcomes with transplantation. So one of that relates to age, and there is no question that the outcomes in an older population, just whether it's ILD or not, are not as good. But the challenging part and the evolving part is, where is that? Up until fairly recently, it was a pretty strict threshold of around 65 years of age that most lung transplant programs would say, you're above that, you know, we really can't be considering you. Now, that has changed, and there's no question that age cutoff is not as strictly applied. I think that there's more of you know, a metric of evaluation above that, but the 65 level is no longer there. But it still has to be considered. Age is no question an important outcome variable, but it needs to be factored as well into, you know, anything else, so-called comorbidities. And it makes a lot of difference if you're, you know, 68 years of age and you're really quite well otherwise, apart from your lung disease. But if you're 68 and you have congestive heart failure, if you have, you know, severe diabetes or something, then that obviously does affect the risk. So all I can say is that that there is some flexibility, some programs more than others based on age, and the decision really comes down to a comprehensive review by by the transplant team and discussions with the individual and the individual's family to come up with a decision, and that's where it's left. So, you know, that 65 is not, you know, there anymore, but it's still, age has to be considered importantly in that decision of transplantation. Coming back, Alyson, there was a question about COVID that came up, you know, specific drugs. If you had a patient with ILD, or I guess, or otherwise, who had COVID, what drugs are being used in those individuals? You're probably not a COVID expert, but...
Far from. So I think the big thing from an ILD perspective is that oftentimes infections can aggravate the underlying ILD and cause what we call an exacerbation. And so in those scenarios, we do tend to use steroids to try to reduce the amount of inflammation within the lungs. Otherwise, there isn't a specific treatment that is given to patients who have ILD and COVID, and a lot of it is supportive. So using oxygen if needed, watching closely, ruling out other things like the presence of blood clots. Yeah, I'll leave it at that if there's anyone else who wants to add in.
There's the previous hype about hydroxychloroquine or Plaquenil, I think has largely faded away. There's some suggestion of remdesivir and antiviral medications that have some benefit in select situations, but largely it's supportive care, which by that we mean oxygen, a ventilator if you need it, and then preventing some of the complications like Dr. Wong mentioned in terms of blood thinners to prevent clots would be one of the other big ones to think about. It's a very big and rapidly evolving topic though.
And there was another COVID type question about vaccinations. If a COVID vaccination comes up, would I be a candidate? And I think, you know, depending on the safety of the vaccination, the specific product, I think that it would be quite clear that individuals that are considered in a more vulnerable group, and Alyson presented the data that would indicate that ILD patients are a more vulnerable group, that it would make a lot of sense to prioritize vaccination if it's safe and if it's effective to individuals with ILD.
One of the other things on that topic is the importance of getting a flu vaccine this year. It's even more important than it ever has been before. The risk of getting influenza and then getting COVID is probably substantial. There are some interesting studies looking at multiple different viral infections at the same time with COVID. And so whatever you can do to minimize your risk of getting other infections or risks of getting admitted to hospital where you might pick up other infections, you should be doing whatever you can to prevent that. So flu vaccine, when it comes available this fall, would be very important for everybody to get.
Just for time, one last question, and then, as I said, there are a few others that we'll try to deal with offline. But coughing is a major problem for me with my ILD. What can be done? Chris and Alyson, do you have any thoughts on that?
I'm happy to start first with some general kind of overview thoughts, and then can hand it to Dr. Wong if she has additional comments. So cough is really difficult in interstitial lung disease. So the reason that cough happens is a little bit of a background, is that when your lungs have something abnormal going on in them, they cough. You have nerve receptors in your lungs, and the simple way to think about this is that there's something in your lungs that's tickling those nerve receptors, and it's your lungs' way of saying, I don't like what's going on here, I'm going to try to cough it out. And that works well if you've got some mucus down there, or maybe a foreign body that you aspirated when you're eating. Cough is a very helpful thing. But when you've got scarring in your lungs, no amount of coughing will ever cough that scarring out. It's in there for good. So cough and cough and cough, it's not going to move. And so you can't think of cough in the same kind of way as you do with those other types of causes of cough. The other important background piece is that cough happens to a variable extent in patients with interstitial lung disease, and it's not always tied to the severity of their disease. Shortness of breath is a reflection of disease severity usually, but cough is often not at all. So just because a cough is getting worse or that you have a bad cough doesn't mean that your disease is getting worse. So cough in a way I think of as more of a nuisance symptom. It can be a lot of nuisance. It can be really damaging to somebody's quality of life, but it's not necessarily a reflection of the disease progressing. So when we think of it in that way as a nuisance symptom, you really want to treat cough if it's significant enough to be causing a lot of discomfort and a lot of impact on quality of life. So the things that I talk to patients about would be if you're coughing to the point where you're passing out from violent paroxysms, or if you're coughing to the point of breaking ribs, or you're unable to sleep, or you're coughing so much that you're unable to go out in public, especially these days, that's where we start thinking about treating cough. And the main reason we think about treating cough in those kinds of situations is that the side effects of the treatments are often worse than the cough itself. The treatments that we have to treat cough in interstitial lung disease kind of fall under two big buckets of therapies. One is that prednisone can sometimes help relieve cough, and prednisone might actually be the most effective. The problem with prednisone is that if you're going to be on prednisone chronically, it has a lot of side effects, and those side effects are really damaging to your body over the long term. The other types of treatments are treatments that decrease the way that your brain responds to that cough signal that comes from your lungs. And those are things like codeine or Tylenol 3s, morphine, and things like that. Some things like gabapentin that act directly on your nervous system. And those often come with side effects of decreasing your level of consciousness, making you a little bit sleepier than usual. And then you have to make a balanced decision. Is your cough better than the side effects that would come with some of those medications? So that's how I generally approach it. Unfortunately, there's not really good evidence on any one medication at this point, although there are still some studies that are ongoing. Alyson, do you have anything to add to that?
Yeah, and just the other thing I would add is that ILD isn't the only thing that can cause cough. So making sure that other things are looked at, like do you have postnasal drip or do you have reflux, and maybe that's what's contributing to the cough. And if we treated those, maybe that would help. And then the last thing was that there's some clinical trials looking at an inhaled cough product in IPF. And I don't know if Dr. Ryerson, we want to mention that or.
Yeah, great point about other causes of cough. That's definitely something to think about. Acid reflux is one of those big ones in ILD. The trial that Dr. Wong is mentioning was a study of, I think, inhaled sodium chromoglycate, which is a bit of a mouthful. But the idea was that might decrease the amount of cough that people are having with IPF. Unfortunately, that trial was a victim of COVID, and that study has been shut down at this point. We'll have to see what happens after the pandemic is over and whether that study gets reopened.
Great, and I would just add that it's been my observation, I don't know how strong the literature is, that sometimes with the oral antifibrotic therapies, there can be an improvement in the cough. Not invariably though, but it sometimes can be an outcome. So I would really like to thank, I guess, first of all those who posed questions. And again, I apologize to those that we didn't get to. And I would also like to thank my co-panelists for, I think, giving a very robust response. And I've enjoyed this format. Hopefully, you as a group have as well. And I'm going to turn it over now to, I guess, Men, or Chris, do you want me to turn it over to you and then you'll advance the next part of the...
It's probably back to Sharon and Men and Fran at this point. So I'll say thank you as well to Dr. Wilcox and Dr. Wong on my own behalf, and hand it over to Sharon, Men and Fran. Thank you.
Yes, I think Men and Fran, we're going to talk about the next part about patient support.
Well, thank you to everybody. That was fabulous. And I hope that everybody that turned in to watch this and be part of the webinar with CPFF gained something and leaves feeling that it was worth their while. One of our big things is looking forward to the support group and in what format are we going to be able to do it. And I've had a fair number of people phoning, leaving messages, etc., and we've gone over what would work and what wouldn't. And we really would like to get onto a virtual, just for safety's sake, for the next little while. And we certainly never had the type of meeting where it was every Tuesday at 1 o'clock or anything like that, but more of a once every 6 weeks type of thing. And so is there any way that, Sharon, we can hear from the people out in the, watching this, or maybe they could contact us on whether or not that would be agreeable to, I know people in Vancouver would, certainly it would be interesting to see a support group globally. I'd love it. Whether or not we could handle it at the very beginning, I'm not too sure. But it's a thought, and I'd like to hear from some of the people watching this, what their thoughts are.
So far, I haven't got anything back yet, Fran.
Oh.
But you know, there's a
You
slight
guys,
delay, so it's okay.
What's happening here? I can't get on.
No, you're on, Fran.
Oh, I am. Okay.
Yes.
Oh.
I just want to say that CPFF, like the Vancouver support group, we are putting our support groups online.
Mm-hmm.
And through our generous support orders with the Clark family, we've actually purchased Zoom packages for the support groups to, you know, facilitate that so that they can meet as many times as they wish and as often as they like. And like you, we are thinking that we would put one across Canada so that people can meet, so that, you know, you can say, oh, this is not unique to me. Someone in Newfoundland feels the same way that I do, and that would be good friendship, so you can make it across the country. And so we're going to try to build that and send that out as well. For those of you who would like to you know, reply to Fran's question, I would say, you know, why don't you put it into the message board and we'll let her know, or email Fran and let her know, and that would be wonderful.
I think the other part of that whole thing too is that the support group certainly is important as a connection for each other and for the patients to chat with one another, trade hints and help and all the rest of it, mentally, physically, the whole thing. Our format actually takes on the ideal of ongoing education, and which is more than, you know, just the let's have a talk kind of thing. So yeah. In that format, Dr. Biagtan and myself were saying perhaps we could have some suggestions. We've always been able to find different topics that are pertinent to pulmonary fibrosis. Maybe not everybody in the room has the specific interest in what we're educating that day, but we do have a speaker at each meeting, and we would like to have that ongoing if that's what the group would like to have at this point. Right. And we can certainly arrange it. So we would like to know topics, but we'd also like to know the overall favor of doing something like that. So the format would be the patients meet, and then we come on at, say, 2 o'clock or whatever, have a speaker, and then question and answer on an ongoing basis for the next 6 months. So in 6 months, we would probably only meet 3 times with this type of format. So
yeah, I think we got 2 responses saying that they would love to have the Zoom for the support group, and perhaps they'll also respond back about those you know, information sessions that you were talking about. I know for CPFF that we are going to be organizing 6 webinars with topics from people suggested from across the country, and we're going to try to find those expertise to come make a presentation and allow people to ask their questions. So that's one of the things that we're committed to providing as well. So maybe we can do some further collaboration together. That would be wonderful.
Yep, and base it out of where the patients are together as a group. and I reach out to the actual patient groups themselves, that I know that within the groups you do form connections. Those have been so important in the past. It's how we've actually kept the support groups going, and being in touch with each other physically in the same room has made a huge difference too. But unfortunately, we know that can't be done right now. It can be done in the future. But there's also people who have never had access to this type of support. And those are the ones that I'm reaching out to, the ones that know how valuable the support group has been. Please, if you have been living in your own little world and not being able to reach out to somebody and saying, I just wish that I could talk to somebody who knows what I'm going through. We do. There are patients just like you, and they know. And they're probably more valuable than any education I could ever give you over anything that is available. And the combination of support and education is really where our aim is. So if you do live in isolated areas, not just in BC, Manitoba, Idaho, you know, name it. If you want to come in from Paris, we'd love to have you. And I think that knowing that there's somebody other than, and I'm not negating medical expertise, even myself, it's not just about medicine, but it is about knowledge, and it is about support. And so that is where we feel the value of these support groups are. And if you want to join us, we're here.
And Fran, I just want to add that CPFF for this month, every Wednesday at 4 p.m. Eastern Standard Time, which is 2 p.m. Pacific Standard Time, we are hosting a social gathering just for the very same things that you expressed, for people to gather together and talk and reach out to each other. And then, you know, we're going to see how well that works out. And if there is interest, then that's something that we can collaborate all across Canada, right? For everybody that wants to participate.
Yep.
And we can go and do roundtables. So maybe this month we would have BC host something, and next month we have Saskatchewan, and so on and so forth. And those are all very valuable things to share with each other. And so that's something that I know the CPFF is doing. So if all of you out there are interested, it's every Wednesday, 4 p.m. Eastern Standard Time, and it's you know, Hope Briefs here. Just log in, click on, and you could just join us. And last week, this just past Wednesday, we talked about who were you walking for, because we were doing a virtual walk with the Clark family, and we asked everyone, and the stories that people had, you know, I'm walking for my dad because he can't do it, but I'm doing it for him. And it's just wonderful. People who just got diagnosed came on and they said that, you know, they never knew that there was a whole group out there that could be so supportive. And, you know, I had one person who had tears in their eyes. They're saying this is a lifesaver, and they're going to see if they can find a support group in their community that they can gather online for now, as you said.
So yes, that's really the biggest part of what we want to get across. The other part is really stressing to the group of you, all of you. I know that breathing is hard work. We all know that. Exercise is even harder work. And through the support group, through our knowledge with one another, we've got to keep that exercise going. We've got to keep some kind of activities going. Social distancing is very, very important around the world. If you can get 2 or 3 people going for a walk, you can still be a group. You can keep that 6 feet distance. You can get outside and get that fresh air. You can, and the work of having to find somebody to go with is going to be difficult probably with some people, and maybe not so much with the others. Get that little support group going in your own area. You know, I've had people from across Canada right now talking to me about what they have done, and it's totally amazing. And the problem with a lot of you, if you're not using oxygen, of course, if you're using oxygen, we know there's an issue right away. If you're not using oxygen, you look great. And what do you mean there's something wrong with you? You know, we don't understand that part of it, is really the comments that we get. But when you're out walking with somebody who has the same issues as you, and whether it's it doesn't have to be a group of 50, it can be a group of 2, it can be a group of 3, and set your own pace, get outside. So important right now, physically and mentally, and I encourage everybody. And if you live in an area that's isolated, reach out to us and let's find out who might be in your area with the same type of disease. And it might not be everybody with IPF. It might be somebody with another type of lung disease caused by rheumatoid arthritis or something along that line. It's still going to cause the same issues. And that in itself is something that we really, really want to do. The other group thing is to get a group together for something like Tai Chi. You know, your local rec centers and whatnot can organize something like that. If you need help with it, you need organizing, you know, maybe we can help. Maybe CPFF can help. You know, phone up the local rec center or church or whatever. There's, you know, even in the smallest of towns, there's somewhere that's got a back room that 4 of you could meet in. So those are our concerns that are coming from the support group that I've been talking with. And something for you all to be aware of, that this can be done, and it can be done through a group, and that mental support is huge. So I think other than that, unless anybody's got questions.
No.
Okay, so we can sign off. Thank you, Sharon, and thank you to Dr. Ryerson, Dr. Wong, and Dr. Wilcox, being fabulous with another great forum. And I don't know if anybody's got anything to add to that, Dr. Ryerson?
Just thank you, everybody. Thank you to Sharon and Men and Fran for helping put this on, and look forward to seeing everybody back again next year, maybe in person and in a video conference.
Yep.
We're hoping.
Yes, so CPFF will be doing a combination, if it's allowed, for next year for in-person. And we also want to say thank you to the Vancouver Patient Group Support folks, Men and Fran. Thank you so much for being part of this and for, you know, collaborating with us. And I want to remind everyone that there is a quick poll after the session is over. We would really welcome your feedback on that so that we can improve upon this technology and what we present to you. And next month, come back to Hope Breathes Here, and you'll find all these sessions back online for you to listen to it again. If you missed a session, like the exercise with Melanie Stevenson, all the things that you could do at home, what Fran had mentioned, it's all there. And so I want to thank everyone again. Thank you so much.